As Director of Clinical Operations and Outcomes for the Medical College of Georgia's Tobacco Cessation Clinic, I hope today everyone will join us in our efforts to make a difference in the lives of patients who use tobacco. Every 8 seconds throughout the world, someone dies from tobacco-related diseases or tobacco-related disorders. In the United States, 45 million individuals are tobacco dependent. And in the state of Georgia, 19% of our population smoke cigarettes. This slide illustrates the state prevalence rates in the United States. The gray and teal-colored states equate to low prevalence, and the darker blue states equate to higher prevalence rates. Throughout the country, approximately 19.8% of individuals smoke. There is research to show that as cigarette tax rates increase, smoking prevalence rates decrease. Looking close at New York, the prevalence rate is low, and yet we know that New York has the highest cigarette tax in the country at $2.75 per pack. Looking at Kentucky, which has the highest smoking rate in the country, 28.3% of their population smoke, and yet the slide indicates that their cigarette tax is low. And yet Georgia is at the bottom of the chart with 37 cents per pack, and yet prevalence rate is below the national average at 19.3%. Many of us are able to think about someone that smoked for a number of years and never received the dreaded news of heart disease or lung cancer. But for the 450,000 who die every year from tobacco-related diseases, they are not so lucky. As this slide shows, it is amazing to think that if you combine all the deaths from suicide, homicide, motor vehicle accidents, AIDS, and drug overdose, that number collectively does not exceed the number of deaths per year from tobacco-related diseases. In Georgia, 11,000 adult lives are lost every year from tobacco use. It's just as concerning knowing that 100,000 of Georgia's youth light up every year. This takes a toll on our healthcare system and our healthcare dollars. Today, it's known that throughout the country, approximately $150 billion are spent every year on healthcare because of tobacco-related diseases and tobacco-related disorders. Whether that is from the healthcare cost of needing medication to treat hypertension or diabetes, or admission to the hospital for pneumonia or a myocardial infarction, or even something as simple as lost productivity from calling in sick at work or taking a cigarette break. It is money that is taken away from an already struggling economy. Let's take a look at the life of some smokers. I think you'll identify with some of them as patients, colleagues, or even family members or friends you've known.
I'm glad we finally got together.
Me too.
Would you excuse me?
Sure.
Welcome to the topsy-turvy world of the cigarette smoker. Smokers can rationalize their behavior and offer all sorts of reasonable-sounding explanations for why they do something so irrational and potentially deadly.
There's a lot of benefits to smoking.
It's just something you got there.
It's a great relaxer.
Like right now, it would be great to have a cigarette in my hand, because then my arm could relax.
I think it actually puts you in some type of focus.
It really makes me feel a lot better. It's a really safe thing to do. It's considered legal.
If you have a drink in one hand, you have to have a cigarette in the other hand, or else you fall over because you're lopsided.
It's something to socialize around.
It's not something that's going to really alter your brain cells.
It's like a good friend.
And it's like yours. You paid for it, you bought it, you're gonna smoke it.
You put so much emotion into a cigarette, especially, if you're really ticked off at somebody, you just smoke and just boom.
And I smoke so other people can live. I can handle the situation now.
All that emotion is in that cigarette you just pitch there and you can walk away from it.
Smoke, kill. Smoke, kill. Smoke. It's just like breath of fresh air.
After all smokers reason, smoking goes so well with so many other things in their lives that not having those cigarettes would leave a huge void.
First thing I do when I get up in the morning is smoke a cigarette.
Oh, I'd smoke 2 or 3 cigarettes before I got out of bed in the morning. When I wake up in the morning.
A cigarette in the morning.
In the morning, while you're waiting for the bus, you smoke a cigarette.
With the coffee.
First one in the morning has to be with my cup of coffee.
I don't have a cigarette without something. Coffee.
Coffee and cigarette.
Gotta have a cigarette with my coffee. Has to.
But cigarettes and coffee, boy.
They go hand in hand.
It's either a cigarette and a cup of coffee.
It's like having peanut butter and jelly.
And it's just not coffee unless I have my cigarette.
If I have a fight with somebody.
A cigarette after lunch.
After lunch.
Before dinner and then 2 after dinner.
Smoking and driving.
Driving in a car.
When I'm out, before I go to bed.
With 2 cups of coffee.
And right before I go to bed. A cigarette after dinner.
Definitely want to smoke after sex. Telephone calls.
The telephone.
Every time you pick up the phone.
After coffee, after meals, after sex, after whatever, you just want to smoke.
It's clear that the act of smoking is much more than a habit to many smokers.
Pack of Camels.
It defines them,
I'll take a pack of Misty Lights, please.
tells the world who they are.
Let me have a box of Marlboro.
It's tough to generalize about smokers, though. Some are aware of the damage that smoking does to their bodies, their minds, and their social acceptance.
Can't smoke in the airport.
We don't live in an age where smoking is tolerated in this country.
You can't smoke in restaurants.
You have a stigma attached to you if you're a smoker.
You can't smoke pretty much anywhere.
You're considered inappropriate.
Yet they keep on lighting up. Others seem completely unaware of the risks and dangers, or at least they're unwilling to acknowledge them.
Crazy, but I see other people doing it, you know, other people who are, say if I see an older guy smoking, I go, well, he's all right. So I'll be all right.
We're here today to focus on the people who are looking for help. Either they're starting to give some thought to giving up smoking, they've definitely decided it's time to quit, or they're already begun the process of quitting and are having trouble sticking to it. Their situations, reasons, and motivations are as unique and varied as the smokers themselves.
It's dirty.
You become a slave to cigarettes.
And it makes your teeth yellow.
It hurts my throat.
And it affects every aspect of your body.
Tender spot inside my lip.
It gives you wrinkles.
My husband hates it.
Clogs your pores.
I don't really like it.
Your skin doesn't breathe.
Really, I don't like it.
Each of these people recognizes that the path to a successful quit is going to be bumpy.
Oh, have I quit?
100 times at least.
Well, let me tell you.
I quit for a day.
I first started smoking when I was 16.
About 8 times.
I smoked for 10 years.
I quit for another day.
I didn't have a cigarette for 12 years.
Twice.
And then I got back into theater.
I'd say 15.
And the director asked me if I would mind smoking for this role.
I tried acupuncture.
And I lit that sucker up.
Wisdom out the window.
It tasted just like I remember it tasting.
About 8 times.
Now I've been smoking for about 4 years.
I couldn't quit.
And I'm just so livid that I'm smoking.
They know that there are going to be barriers, pitfalls, and temptations all along the way that can knock them off the path at any time.
There's always somebody out there, a friend, who has a cigarette, who also smokes, and says, come on, you can just have 1 cigarette with me.
They know they're hooked.
The addiction to smoking is terrible. It is horrendous. It is, you cannot be your own person because you could be sitting in a movie, you have to go to the men's room to have a cigarette. You can be sitting in a Broadway play, you have to walk out to have a cigarette. You can be sitting anywhere or doing anything, and you have to stop in order to satisfy your addiction and smoke your cigarette.
And they'll go to almost any lengths to get that cigarette.
I went looking for butts.
I rolled pencil shavings to smoke a cigarette.
And I found a butt in the hallway.
First, I tried to keep it to the butts of the cigarette butts of people that I knew.
These smokers clearly need help, support, encouragement, and most importantly, techniques to help them cope and become smoke-free.
I don't need somebody to talk to. I need someone that can talk to me. A professional who knows what I'm experiencing, what my body's experiencing, and can give me instruction and guidance and support in getting through that.
During today's program, information will be provided to help build knowledge and skills to effectively guide and support patients that want to quit. A summary of techniques how to do this can be found from the pocket guide provided, which can be downloaded for free at www.nursesfortobaccocontrol.org. All of today's information and the pocket guide are based on national recommendations from the U.S. Preventive Health Services Clinician Guideline for treating tobacco dependence. It is also based on the University of California, San Francisco's RX for Change Clinician-Assisted Tobacco Cessation Curriculum. Since 1994, there have been clinical practice guidelines for clinicians to access and apply at the bedside. Based on more than 6,000 clinical trials and meta-analyses, the most recent guide continues to emphasize the importance and value of each healthcare provider, regardless if that is a nurse, a physician, or respiratory therapist. All providers need to integrate tobacco cessation interventions in daily practice. Before discussing specific steps for intervening with tobacco-dependent patients, let's review 3 important principles. First, treating tobacco dependence requires a comprehensive approach to address the 3 cycles of nicotine addiction. Addressing all 3 is critical for success. The behavior cycle involves breaking old routines, such as hand-to-mouth of smoking a cigarette or smoking while drinking coffee. That's where the value of counseling comes in to learn new, healthy routines, such as drinking water and not smoking. The social or emotional cycle involves breaking old routines of smoking when stressed or socializing with friends. That's where the value of counseling comes in again, to learn new healthy coping routines such as exercise. The physical or biological cycle involves breaking the need for a nicotine fix. That's where the value of medication comes in, to ease the suffering from cravings and withdrawals. The second principle is about the power of nicotine addiction, and it cannot be underestimated, just as the opening video clip demonstrated. It is the most powerful drug and the hardest drug addiction to kick. Substance abuse specialists repeatedly report that it is harder for someone to quit smoking than to quit using heroin. As depicted in this slide, within seconds of nicotine entering the bloodstream, nicotinic receptors in the brain are stimulated. Specifically, research has shown the effect of nicotine on the nicotinic receptor sites in the ventral tegmental area and how that results in the release of dopamine. The effect of nicotine with the dopamine reward system leads to the pattern of self-medicating by smokers and helps to explain nicotine addiction behavior. Research has shown that the half-life of nicotine is approximately 2 hours. So when not getting the fix, signs start surfacing such as irritability. The same happens when smokers quit cold turkey. The good news is that most withdrawal symptoms peak over 1 to 2 days and subside within 2 to 4 weeks. But without help, for some, it is a long and bumpy 4 weeks. To keep patients from starting the addiction cycle over again, which leads to a chronic relapsing condition, healthcare providers must work on the barriers to effective smoking cessation interventions, such as withdrawal symptoms, which serve as a negative reinforcer, and pleasure responses, which serve as a positive reinforcer. To emphasize the power of nicotine addiction and its behavioral and physiological impact, let's consider this simple math exercise. It is known that 1 cigarette typically requires 20 puffs or inhalations to consume. That's also 20 hand-to-mouth behaviors and 20 hits of nicotine. Imagine if someone smoked a pack a day. That's 20 cigarettes or 200 puffs or inhalations consumed and 200 hand-to-mouth behaviors and 200 hits of nicotine. All of that performed in just 1 day. Imagine doing that every day for a year. That's 73,000 hits of nicotine and hand-to-mouth behaviors. Take it a step further. Imagine doing it every day for 20 years. That's 1.4 million hits of nicotine and hand-to-mouth behaviors. That helps to pull together why it is so hard to quit. All 3 cycles of addiction must be addressed: behavior, emotional, and biological. The third important principle is that it's not the nicotine that kills. Nicotine addicts. It's the toxins in the cigarettes and the toxins in the tobacco that damages at the molecular and the cellular level. In one cigarette, there are over 4,800 toxins, including carcinogens. The tobacco industry manipulates the pH of the tobacco so that it gets into the bloodstream very, very fast. Such chemical manipulation of the pH includes adding toxins as ammonia, formaldehyde, and cadmium in each cigarette or each tobacco product. The faster the nicotine delivery, the faster the addiction, which makes great profits for the tobacco industry and deadly outcomes for the consumer. The power of addiction and the danger of toxins cannot be underestimated. But how many times have we heard this?
Well, my doctor didn't say anything about my smoking, so it can't be that bad, right?
Just as the video clip points out, many patients never hear about tobacco cessation from their providers. In fact, 36% of healthcare providers do not intervene. As this slide indicates, there is evidence to support the effect of healthcare provider interventions. A meta-analysis of 29 studies found that patients are twice as likely to quit when an intervention is provided by healthcare providers compared to no help by healthcare providers. Not only does the USPH guideline for treating tobacco dependence recommend that healthcare providers have the tobacco conversation, in acute care settings, the Joint Commission requires assessing and intervening with tobacco-dependent patients. To help with the JC compliance standards, providers can follow the USPH guidelines 5A's framework. As depicted in the pocket guide, there are steps that can be done in less than 3 minutes. The first A stands for ask. Ask about tobacco use and when was the last time it was used. Don't just say cigarettes, because there are a whole host of tobacco products that our patients are using these days. Cigarettes are the most common form of tobacco use. However, smokeless tobacco products are gaining popularity because of the restricted smoking regulations, and in fact, there is concern about poly-tobacco use, where individuals are using smokeless tobacco products in restricted areas, then lighting up later where smoking is allowed. Many patients think of cigars as okay to use, when in fact there are cigars on the market that can deliver up to 480 milligrams of nicotine in one cigar, compared to 1 milligram of nicotine in one cigarette. Critex are another tobacco product. They are also known as clove cigarettes, consisting of cloves and tobacco. Critex deliver twice the amount of tar and nicotine and have an extremely dangerous compound in them called eugenol, which is used for anesthetics, and it can lead to hemorrhagic pulmonary edema. Biddies are another tobacco product to ask about. Biddies are marijuana-looking cigarettes that are made from Hindu leaves and flavored tobacco. The youth are particularly attracted to them because of their colorful packages and wide assortment of flavor, such as chocolate, mango, and vanilla. However, biddies have 3 times the amount of tar and nicotine than cigarettes. Hookah pipes and hookah bars are particularly popular in college towns and cities. Following an Eastern tradition, individuals come together to socialize and smoke from one pipe with multiple mouthpieces. Most hookah bars offer menus with a variety of customized selections, such as raspberry and mocha or licorice and vanilla. Although the science is relatively new, research has found that a typical 45-minute hookah pipe session is equivalent to smoking 100 cigarettes. So when asking the question about tobacco use, it's important to include all of these tobacco products. In addition, there are alarming new tobacco products that are emerging, known as PrEPs, potentially reduced exposure products. Arriva is compressed tobacco and marketed to help quit smoking or use when smoking is not allowed. Quest cigarettes are marketed for a step-down approach to quit with lower levels of nicotine. And the latest fad are the snus tobacco products. Orbs, which are compressed tobacco similar to Tic Tac mints. Sticks are compressed tobacco shaped like toothpicks. And stabs are compressed tobacco similar to Listerine mouthwash strips. These two should be assessed when asking the question about tobacco use. The second A is advise. Keep it simple. Quitting smoking or quitting your tobacco use is the single most important thing you can do for your health and the health of others. The third A stands for assess. Keep it simple again. Assess readiness to quit. Find out if your patient plans to quit immediately or within the next 30 days, or is it later in a few months, or do they not want to quit at all? The Pocket Guide shows phases of the trans-theoretical model of change, and that helps to guide strategies or techniques to quit. If patients are not ready to quit now or within 30 days, simply encourage them to start thinking about quitting and provide referral numbers for help when they are ready to quit. An important element in assessing patients at this point also includes assessing their level of nicotine dependence. This can be found in the Pocket Guide. It is referred to as the Fagerstrom test for nicotine dependence. It is the standard scale of assessing for nicotine addiction. Based on 6 questions, the scores range from 0 to 10, with 5 indicating moderate dependence. Just as patients are assessed for pain in our acute care settings or healthcare settings, nicotine dependence needs to be assessed as well. The fourth A stands for assist. As busy healthcare providers in the acute care setting in particular, this may not be a simple step to accomplish. However, assist simply means to set a quit date and develop a plan. At the very least, every healthcare provider should be able to provide the 1-800-QUIT-NOW toll-free number for free counseling, or provide referral information to a local community center that provides tobacco cessation. The last A stands for arrange. Research has shown that the more follow-up visits or encounters, the more positive the cessation outcomes. This can be done either face-to-face through group counseling or individual counseling, or online assistance or even telephone counseling. As this slide depicts, even one follow-up call can increase the success rate by 12%, and more than 4 follow-up encounters can increase the success rate to 21%. Let's see how the 5 A's apply to a couple of scenarios. Let's say when you're giving advice to a patient about quitting, this is the response you hear.
I already have cancer. What's the point in quitting?
That clip helps to emphasize the importance of reinforcing that today's technology and science has advanced to the point that cancer is considered a chronic disease, and healing will be enhanced and quality of life will be improved if, while living with cancer, there are attempts made to quit smoking. Just as treating cancer as a chronic disease is made, we must approach tobacco dependence as a chronic disease as well. What about if there is a patient in pre-op and within seconds of the tobacco conversation, this is the response?
I wake up every day at 5 a.m. just so I can work out. I keep myself in good shape, so what's the big deal about me having a few cigarettes every day?
That clip helps to emphasize that there are patients that believe exercise, especially aerobic exercise, will mitigate the harmful effects of smoking. But in reality, it does not, and eventually lung capacity will deteriorate and oxygen delivery will be compromised. What about if a patient presents to the emergency room And during that visit, there's discussion about treatment options for tobacco dependence. And the patient responds like this.
Nah, I think I'd rather quit cold turkey and do it on my own. I don't need no help.
That clip illustrates that many patients know of individuals that have been successful quitting by cold turkey. But the truth is, only about 7% are able to do that and remain smoke-free long-term. Plus, research has shown that success rates will double or even triple if counseling and pharmacotherapy are used in combination to quit. The best outcomes in life are always associated with a plan, whether it's a treatment plan to help manage diabetes or regain activities of daily living after suffering a stroke. Nicotine withdrawals are not fun, so our patients need to have a plan that's proven to work. Pharmacotherapy options should be an integral part of that plan. As of today, we now have 7 FDA-approved products available to help patients quit. 3 are over-the-counter and 4 require a prescription. This slide provides an overview of a meta-analysis of 145 clinical trials. And it is clear to see that regardless of the medication, which is depicted as the yellow bars, quit rates are twice as high as the placebo, which is depicted by the blue bars. The cost of medication is always an issue. Some patients will have the ability to pay through their health plans, and others will have to pay out of their pocket. But helping patients see that this is a short-term investment for having more quality of life and control of life, instead of nicotine being in control, and more dollars to spend in life or save for life instead of spending on cigarettes. For several of the medications, especially the generic, which are depicted in the yellow bars, it is the same daily cost or lower than a pack of cigarettes. Helping patients calculate the money they are spending now on cigarettes can show the money they can use for something else. Quitting any time is good, but especially in today's economic downturn, just look at the money lost to cigarettes over a smoker's lifetime. You can help patients calculate the money they are spending now on cigarettes and show them the money they can use for something else. Quitting any time is good, but especially in today's economic downturn, just look at the money lost to cigarettes. Taking a closer look at the 7 first-line medications for tobacco dependence, it is important to know that one size does not fit all, and each treatment option or options must be weighed carefully for the risk and benefits of using either one of these medications or using 2 or more in combination. Regardless of the choice, medication and counseling go hand in hand. Best outcomes occur when patients are fully engaged in the process. Learning how to change behaviors that they have performed for years takes time and takes concentration. Cold turkey or waiting out 2 to 4 weeks for the withdrawals to subside can hinder successful long-term tobacco abstinence. This slide shows the options that have been available since 1984, with the Nicorette replacement therapy gum, or referred to as NRT gum, being the very first, and Chantix being the most recent. The Pocket Guide provides a nice overview of all of the pharmacotherapy options, but let's review a few key points for each. First, about nicotine replacement therapy, or NRT. Even though patients will receive a drug, nicotine, they will not receive the 4,800 toxins that are associated with each cigarette. Thinking about 1 cigarette being equivalent to 1 milligram of nicotine helps to put in context why the dosing is as it is for NRT medication. If a patient smokes 1 pack a day, that's approximately 20 milligrams of nicotine needing to be replaced per day while making the quit attempt. Second, as with all medication, over-the-counter or prescription, benefits and risks must be considered. NRT has precautions and contraindications that must be observed. NRT gum was the first product to help patients quit. Initially, NRT gum required a prescription. Now the gum is over-the-counter and comes in 2 and 4 milligrams and a variety of flavors. It is dosed based on the number of cigarettes smoked per day. It is chewed not like regular gum, and that is the usual problem when patients are not successful with it. It is chewed slowly, and when the tingling sensation occurs or flavor is tasted, then the gum is parked in the cheek. This is repeated for at least 20 minutes. If not done for 20 minutes, there will be a subtherapeutic effect of the nicotine. The NRT patch was the second product on the market. It too started out as a prescription and now can be purchased over the counter. The leading problem with misuse of the patch is cutting it in half and inappropriate dosing. The strength of the patch is based on the number of cigarettes smoked per day and provides sustained nicotine delivery over 14 to 24 hours. Key things to remember about the NRT patch include not cutting it in half, removing it at bedtime if there is conditions of sleep disorders, and also reminding patients that it is okay to bathe or swim with the patch. The NRT spray was the third product on the market. It continues to require prescription and typically is reserved for those patients that are highly dependent, and the spray provides intermediate nicotine delivery over 1 to 2 hours. The NRT lozenge was the fourth product to enter the market. Available over the counter, this product provides intermediate nicotine delivery over 2 hours, and it is dosed based on the timing of lighting up the first cigarette for the day. The leading misuse of the lozenge is biting it like candy or not dissolving it in the mouth long enough. To be therapeutic, it must dissolve over 20 minutes. Similar to the NRT gum, nicotine is absorbed better in alkalinic environments, so food and beverages should be withheld 10 to 15 minutes prior to use, during use, and 10 to 15 minutes after use. The last product to enter the market is the NRT inhaler, which requires a prescription. It works best for high nicotine dependence, resembling a cigarette and puffed as if trying to light a pipe. This product provides intermediate nicotine delivery over 1 to 2 hours. Pulling the pharmacotherapy information together helps by looking closely at this slide. It shows the plasma nicotine concentrations of the NRT products compared to a cigarette. And it shows on the bottom of the graph the delivery time of the nicotine. First, nothing gets in the bloodstream any faster than a cigarette. The NRT product that comes the closest to that is the nasal spray. With all NRT products, knowing the concentration and timing of nicotine delivery is important. Research shows that it takes an average of 7 to 10 quit attempts for long-term success. So getting dose right and medication advice right is critically important. The only first-line oral medications that are FDA approved for smoking cessation are Zyban and Chantix. Zyban, also known as Bupropion SR, has been available by prescription since 1997. It has consistently had good results with its action on the dopamine and norepinephrine neurotransmitters to help patients quit. However, as this slide depicts, Zyban must be used cautiously with several conditions, such as a past history of seizure disorder or cranial trauma, and it has several contraindications, such as current seizure disorder and eating disorders. It also has known drug-to-drug interactions that must be carefully considered. Zyban dosing recommendations are provided in the pocket guide, but key is titrating the dose up gradually for 2 weeks prior to quitting cigarettes. Also, research has found that using Zyban in combination with the NRT patch and/or the NRT gum or lozenge doubles the cessation rate. Chantix is the last drug to discuss. After 10 years of no new smoking cessation products, varenicline or Chantix became available by prescription in 2006. Through its action as a partial nicotinic receptor agonist and total nicotinic receptor antagonist, evidence supports the effectiveness of its use. Similar to Zyban, titrating the dose up prior to stopping cigarette use is important. For Chantix, this is done over a 1-week period. Also, patients must be closely evaluated for psychiatric mental health disorders prior to prescribing Chantix. In summary, each of the pharmacotherapy options have evidence to support their effectiveness. However, it is important to remember behavioral counseling used in conjunction with medications will double or even triple quit rates. As the yellow bars depict on this slide, an active drug can increase long-term success rates up to 23%. And if counseling occurs with medication, the success rate will double or even triple. It is the comprehensive approach to tackle all cycles of nicotine addiction: the behavioral, routines such as hand-to-mouth; the psychosocial, smoking when stressed or socializing with friends; and the physiological, that will make a difference, not just taking the medication. Now let's pull all of this information together and see how you would respond to this question.
Why do I need drugs to quit? I don't like putting drugs in my body.
Advising this patient in the video clip that a short-term medication will not only help to slowly reduce the dependence on nicotine, but more importantly, immediately eliminate all the other toxic substances that are found in cigarettes. Taking one final look at a video clip that reminds us of those patients that cause us to stop and pause when questions like this are asked.
You don't know what it's like. You've never smoked.
We cannot remain silent. We do not have to have the addiction to help someone quit. We have what it takes: knowledge and skills. Plus, all of us have had experience with changing some behavior in our own lives. As healthcare professionals, use your skills and knowledge. Start making a difference today. Sit down and talk to patients about quitting or refer them to those that will. Every day in our acute and critical care environments, healthcare providers are faced with teachable moments. Do not ignore them. Our patients are listening. Let's help to make a difference and save their lives.